cancer. I will go over biochemical recurrence and its impact on oncological outcomes, about the options salvage lymph node dissection. We will cover PET imaging prior to salvage lymph node dissection, look at some salvage lymph node dissection series, and also at PSMA radio-guided surgery, talk about salvage radiation treatment in patients with persistent PSA, and with some data on salvage radical prostatectomy. So if we look at the typical cohort of patients who underwent radical prostatectomy, in this case, 14,500 patients, all didn't have neoadjuvant or adjuvant therapy, and about 20 to 30% of men have biochemical recurrence within a follow-up of 50 to 60 months. But when looking at high-risk patients only, this rate is much higher. They have a 10-year recurrence rate of 45 to up to 65%. So it represents a problem. I am showing this because a lot of urologists don't actually are aware of this. This is in the guidelines for a few years, that they removed the threshold for PSA to define a recurrence. They specifically state that after radical prostatectomy, there's no specific PSA threshold defining recurrence. The EAU guideline panel performed a systematic review on the prognostic value of biochemical recurrence following treatment with curative intent. And they came up with a risk stratification for biochemical recurrence called the EAU low risk and high risk biochemical recurrence groups. Low risk biochemical recurrence would be defined as a PSA doubling time of more than 1 year plus a Gleason score in pathology of below 8, and all other patients are considered as high risk biochemical recurrence patients. So when considering salvage treatment in these patients, one should discuss this risk stratification and the life expectancy of the patients to decide for salvage treatment. We externally validated this EAU BCR risk groups, and indeed it does stratify patients into good risk groups looking at metastasis-free survival and cancer-specific survival versus into bad risk groups. What is interesting is that the EAU BCR risk classification could potentially be used as a decision tool for salvage radiotherapy. We presented that at the EAU meeting, and it's already in press for publication in a journal, and will come out soon as the original article. Basically, it shows then that when we look at EAU high-risk BCR patients only, they had significantly better survival when salvage radiotherapy was delivered at an early time point compared to no salvage radiotherapy or late salvage radiotherapy. And interestingly, when looking at EAU low-risk patients, BCR patients only, there was no difference, no matter if you gave salvage radiotherapy or not. So potentially, one could observe these patients with low-risk EAU BCR. And the study also summarized that increasing use of PET-CT has led to a shift towards early detection of low-volume metastatic prostate cancer, and that has contributed to an interest in metastasis-directed therapies such as salvage lymph node dissection, which we will discuss now. So looking at PET imaging, when we looked at choline PET a decade ago, we see that PET-CT correctly predicts the presence of lymph node metastasis in the majority of patients with biochemical recurrence after radical prostatectomy, but it might underestimate the extent of nodal recurrence and miss micrometastatic disease. And this is also true when you look at PSMA PET imaging, which has a increased detection rate, but still misses micrometastatic disease. This is a randomized study which was published in 2020 on staging with PSMA PET-CT, the PRO-PSMA trial. And in this trial, the authors were able to show that PSMA PET had a 27% greater accuracy than that of conventional imaging, and subgroup analysis showed the superiority of PSMA PET for patients with pelvic nodal metastasis and for patients with distant metastasis. But when we look at accuracy of PSMA PET for the detection of low lymph node metastasis before salvage lymphadenectomy, we also see some missed positive lymph nodes. Sensitivity is about 76%, high specificity. So in this study, we concluded that extended salvage nodal dissection is needed even in patients with PSMA-based PET-CT scan. This is a systematic review from Australia, summarizing the evidence on PSMA PET-CT and its sensitivity and specificity. And what the authors summarize is that, as we know, the higher the PSA level at recurrence, the higher the positive scan rate. And this leads, I don't know if it's the case here, but in Germany at least, this leads to urologists waiting for higher PSA levels to get a PSMA PET, even up to 0.5, and to suggest no treatment if nothing is visible in PSMA PET. However, to look at this, we have looked at PSA levels at the time of salvage therapy after radical prostatectomy and its influence on outcomes. And we saw that after a median follow-up of 6 years, patients who received salvage radiotherapy at the level PSA level of above 0.25 had a significantly higher all-cause mortality. So waiting to deliver salvage radiation therapy up until a PSA level of 0.25 can be done, but one should not wait too long for higher PSA levels just to detect something on PSMA PET and decide for treatment options. And regarding this, there was a nice editorial by Roppy Waller and colleagues highlighting this. The greater likelihood of identifying prostate cancer with novel PET-CT imaging is altering but not necessarily improving treatment paradigms. And dilemma arises when metastases are identified on PSMA PET without apparent disease on conventional imaging. There are clinical trials underway which will answer these questions. Currently, the guidelines do recommend to perform PSMA PET-CT at PSA recurrence in patients fit for curative salvage treatment, but they added this in the new guideline version this year to be more clear and and stated that treatment should not be changed based on PSMA PET-CT findings in view of current available data. Coming to salvage lymph node dissection series. So this was a study done within the EAU Young Academic Urologist Prostate Cancer Working Group of the EAU. 27 salvage lymph node dissection series have been selected for the systematic review, and biochemical recurrence-free survival was quite low in all of these studies. 5-year biochemical recurrence-free survival, 6 to 31%. But main drawbacks of these studies were that almost all of them were retrospective, single center, heterogeneity between series in terms of included patients, that they have adjuvant treatment, what was the definition of progression, and there was a rarely long-term follow-up in these studies. These are older salvage lymphadenectomy series which used choline PET as a basis. And as you can see, the results were very heterogeneous. 13 to almost 80% in this different series achieved a complete biochemical response after salvage lymph node dissection. And this obviously depends on included patients in the series, but the majority of patients have a biochemical recurrence after salvage lymph node dissection. When looking at more recent series, which used PSMA PET imaging as a basis, there's better outcomes with higher rates of patients having a complete PSA response after salvage lymphadenectomy, with up to 64.5% complete PSA response. In the study in the last line, this is a multicentric study by Prostate and colleagues looking at optimal candidates for salvage lymphadenectomy, defining it as patients with a Gleason grade group of lower than 5, longer time from prostatectomy to biochemical recurrence, and less than 3 positive spots at PET-CT and a lower PSA value. This is a study from our department comparing standard of care, which in this study meant immediate or delayed androgen deprivation therapy administered at PSA progression versus patients who had metastasis-directed therapy for PET-detected nodal oligorecurrent prostate cancer. And patients were matched. This was a retrospective study, but showing that patients who had metastasis-directed therapy did better than patients who had the standard of ADT. What do the guidelines currently state on salvage lymph node dissection? They highlight that it is no standard treatment. They say there's a high-level evidence for oncological value of salvage lymph node dissection is missing. And recently, they included a multicentric retrospective study in the guidelines, which had long-term outcomes of salvage lymph node dissection, which reported to be worse than previously described in studies with shorter follow-up. I will show this study. This is a study from a multicentric cohort. Our patients were also included in the study, 189 patients. And at long-term, biochemical recurrence was seen in almost 90% of patients. And after salvage lymph node dissection, a high proportion of patients received ADT. 45 of these patients died from prostate cancer. But what needs to be highlighted in this study is that it's a quite historic cohort. 11 centers. Surgery was done between 2002 and 2011. And as you can see from this table, most of these salvage lymph node dissections were performed based on choline PET, more than 80%. 18% of patients had ongoing ADT. A lot of these patients had more advanced disease with retroperitoneal positive lymph nodes, and the PSA at median was quite high. So this doesn't represent an early BCR patient cohort. And what's more interesting is that there were 21% of the patients who received salvage lymph node dissection where the lymph node actually wasn't found. There was a negative histology. So the guidelines state that metastasis-directed therapy should only be offered within a clinical trial setting or well-designed prospective cohort study. To decrease the rate of patients who have a negative histology after salvage lymph node dissection, some centers have introduced PSMA radio-guided surgery, so have we. And this is done by a gamma probe, which can be used intraoperatively, looking at acoustic and visual feedback. It needs a preoperative injection of technetium-labeled PSMA ligands. And when we compared our patient group, which got a conventional salvage lymph node dissection without the gamma probe, to patients with the radio-guided approach, we were able to see that in short-term outcomes, patients who underwent PSMA radio-guided surgery had lower PSA 6 weeks after surgery. We saw in the conventional salvage lymphadenectomy patients that 31% didn't have the lymph node metastases found, whereas in radio-guided surgery, all the visible lesions were confirmed pathologically. And also in the cohort with PSMA radio-guided surgery, a higher proportion of patients had a PSA decline of more than 50%. A few years ago, a company also developed a robotic drop-in gamma probe, which can be used in the robotic setting. So we are currently performing salvage lymph node dissection robotically and in the open fashion. Conclusions regarding salvage lymph node dissection are that retrospective data suggest that surgery may represent an important therapeutic modality in the management of nodal recurrence, but it's crucial to identify patients who will benefit from surgical treatment. Historic cohorts have mostly also included really advanced disease with multiple positive lymph nodes. This should probably not be done. PSMA radio-guided surgery may improve oncological outcomes after salvage lymph node dissection, and we need a prospective randomized study. Coming to the next treatment option, I will talk about salvage radiation treatment in patients with persistent PSA. So persistent PSA we usually define as a PSA of 0.1 or above after radical prostatectomy, and we see it quite a lot. This is a cohort from our department showing that up to 9% of patients have persistent PSA. And when we look at these patients, it's really a bad prognostic factor. At 15 years, the metastasis-free survival and cancer-specific survival is much worse in patients who did not reach an undetectable PSA after radical prostatectomy. In multivariable analysis in this study, we saw that higher preoperative PSA, more advanced pathologic tumor stage, Gleason grade groups 3 to 5, positive surgical margins, and PN1 were all associated with an increased risk for persistent PSA. And what's interesting is when we look at the entire cohort of patients with persistent PSA, although they have a bad prognosis, these patients, when they receive salvage radiotherapy, they have much better cancer-specific outcomes when compared to patients not receiving salvage radiotherapy. And what's more, even more striking is that even when we look at patients with persistent PSA and positive lymph nodes at radical prostatectomy, you see a huge difference in cancer-specific survival when these patients receive salvage radiotherapy versus no salvage radiotherapy. In contrast, I wanted to show this study from Italy, Prostate and colleagues who showed a little bit different data. They looked in this study not only at persistently elevated PSA, but also at patients who had undetectable PSA and then rising PSA. And they identified 3 groups of patients who would profit from salvage radiotherapy. And among the patients with persistent PSA, they stated that only patients with PSA persistence after radical prostatectomy with a Gleason score of 7 or lower would potentially profit from salvage radiotherapy. However, this was in contrast to our study, where we even in the advanced cases with PN1 disease and PT3, these patients did profit from salvage radiotherapy. So the current guidelines state that patients with PSA persistence after radical prostatectomy may benefit from early aggressive multimodality treatment. But again, here we don't have prospective data. The guidelines do recommend for persistent PSA that a PSMA PET should be done at a PSA level of above 0.2 if the results will influence subsequent treatment decisions, and that these patients should receive salvage radiotherapy. And at last, I would like to talk about salvage radical prostatectomy. So what do the guidelines state about management of PSA failures after radiation therapy? They include the systematic review of Valle and colleagues, which compared studies on efficacy and toxicity of salvage radical prostatectomy, salvage HIFU, salvage cryotherapy, and salvage brachytherapy. And they state that there were no significant differences with regards to recurrence-free survival between these modalities in the systematic review. But the authors reported that severe GU toxicity exceeded 21% for HIFU and radical prostatectomy, whereas it ranged only from 4.2 to 8.1% with re-irradiation. So it's clearly highlighted that evidence is of low quality in this setting, and there can be no recommendations made regarding the choice of any of these techniques. But there's a lot of data on salvage radical prostatectomy series available. This is a multi-centric database. We also included our patients here, 414 patients with salvage radical prostatectomy. And what's most important to highlight here is that in these older cohorts, patients were included with quite advanced disease. More than 50% had PT3 disease at salvage radical prostatectomy, and 16% had positive lymph nodes. This shows functional data, 395 patients, and a lot of patients, 1/4, 25%, had severe incontinence at 12 months, which was defined as 3 or more PETs per day. And so in a systematic review, it was shown that results are very heterogeneous in this series. So this also depends on which patients are included, obviously, but 5-year BCR-free survival ranged widely from 34 to 83%. Urinary continence was really all over the place, ranging from 22 to 90%. And erectile function also from 0 to 32%, which shows really that patients included were different. What do the guidelines state specifically about salvage radical prostatectomy? In general, it should be, according to the guidelines, only considered for patients with low comorbidity and obviously life expectancy of 10 years and maybe more. Pre-salvage radical prostatectomy PSA of below 10, a biopsy Gleason score of 7 or lower, no lymph node involvement in the staging prior to salvage radical prostatectomy at the CT1 or 2 stage. So we recently validated these EAU criteria in our multicentric cohort. 1,030 patients who underwent salvage radical prostatectomy at 14 centers, and about 22%, this shows what we have seen in the slides before, only 22% fully met the EAU recommended criteria for salvage radical prostatectomy. And interestingly, the EAU compliant group experienced much more favorable pathological and oncological outcomes, and even better functional outcomes, 80% versus 63% wearing no pads at 1 year. And as I said, had significantly better metastasis-free survival. So conclusions for salvage radical prostatectomy are that there's a large body of data, probably larger than the other salvage options, in very well-selected patients. Efficacy and morbidity of the procedure is acceptable, but patients really must be given a realistic counseling about potential complications, the very high rates of incontinence and erectile dysfunction, and have to be talked about alternatives. Thank you.